All right, welcome to Chapter 9, the Hematopoietic System, also known as the factory, the recycling center, and the security team of the body, all rolled into one. When we say hematopoietic, we literally are talking about blood making. The system is responsible for producing red blood cells, white blood cells, and platelets, maintaining them and getting rid of them when they've outlived their usefulness. Think of it as a very well-regulated assembly line, most of the time. From a histotechnology perspective, this chapter is a big deal. Blood and bone marrow specimens show up in biopsies, aspirates, smears, and surgical pathology, and subtle cellular changes often tell us exactly what's going wrong long before imaging or symptoms catch up. If the hematopoietic system fails, everything downstream is affected. Oxygen delivery, immunity, clotting, healing. The average adult produces over 2 million red blood cells every second. That's productivity most of us can only dream of. This slide is your roadmap for the chapter, and yes, I promise everything here actually matters. By the end of this chapter, you should be able to explain where blood cells come from and what they do, recognize common hematologic diseases and how they present clinically, understand CBC values, indices like MCV and MCHC, and what they actually mean in real patients. Correlate blood smear morphology with disease processes, and appreciate why bone marrow and lymph node biopsies are such powerful diagnostic tools. From a lab standpoint, this chapter connects numbers on a report to what you see under the microscope. It's where abstract values like low hemoglobin become very real things like hyperchromic cells or blasts, where they absolutely do not belong. You are not just identifying cells, you're interpreting patterns, ratios, and maturation stages, which is why histotechnologists are essential members of the diagnostic team. You do not need to memorize every reference range today. You do need to understand why those ranges change, though. Before we jump into the diseases, we need to make sure we're all speaking the same structural and functional language. The hematopoietic system includes blood, which is the circulating tissue, bone marrow, which is the production site, and lymphoid tissues, such as lymph nodes, spleen, and thymus. Also, the mononuclear phagocytic system. This is the macrophages doing cleanup duty. The immune system, because defense is everyone's job. Now let's talk tissue because that's our comfort zone. Bone marrow. This is ground zero for hematopoiesis. Histologically, you'll see a mix of hematopoietic cells at various stages of maturation. Adipocytes, which increase with age. It's rude, but true. Sinusoids that are allowing mature cells to enter circulation. If the marrow looks too empty or too crowded, that's a red flag. Blood vessels. They're not just plumbing, they regulate cell trafficking, inflammation, and immune surveillance. The spleen. The spleen is the quality control department. It removes old and damaged red blood cells, filters the blood, and plays a role in immune response. Histology hint here is that red pulp versus white pulp matters a lot in the spleen. Lymph nodes equal immune activation hubs, and the thymus equals the T cell boot camp, mostly important earlier in life. Analogy time. If bone marrow is the factory, the spleen is the recycling center, lymph nodes are security checkpoints, and blood is the delivery truck that never stops driving. Some worthless knowledge. Red blood cells don't have nuclei, not because they forgot them, but because losing them makes more room for hemoglobin. They're minimalists designed at its finest. Okay, let's break down blood into basic components because while we casually say blood, it's actually a very busy, very organized tissue. Plasma is the liquid portion of blood. Think of it as the highway system. It's mostly water, but it also carries proteins such as albumin, globulins, and clotting factors. It also has electrolytes, hormones, nutrients, and waste products. From a histology perspective, you don't see plasma on a routine blood smear. It's what everything else is floating in. But when plasma proteins are abnormal, like in multiple myeloma, you absolutely see the consequences on smears and lab values. An analogy here, Plasma is the delivery truck, the cells are the packages. The next component is serum. Serum is what's left after blood clots. So here's the key distinction. Plasma equals serum plus clotting factors. Serum equals plasma minus clotting factors. This matters clinically because many lab tests specify whether they require plasma or serum, especially coagulation studies. If fibrinogen is present, that is plasma. If fibrinogen is gone, then you're looking at serum. If you've ever wondered why some tubes have anticoagulants and others don't, this is why. Now we get to the stars of the show, the formed elements, meaning the cellular components. Erythrocytes, or red blood cells. They carry oxygen via hemoglobin, they are anucleate, and they are biconcave discs. Their shape maximizes surface area for gas exchange and makes them very sensitive to membrane or hemoglobin defects. That's why shape changes, such as in sickle cells and target cells, are diagnostically cold. Then we have leukocytes, which are also white blood cells. These are your immune defense cells, and yes, they are vastly outnumbered by red blood cells, but they do all the drama. They include neutrophils, lymphocytes, monocytes, eosinophils, and basophils. White cells are where morphology really matters, so nuclear shape, chromatin pattern, granules, and cytoplasm color, all of it. And then lastly, platelets. Platelets are not true cells. They're fragments of megakaryocytes. Their job? Clot formation, vessel repair, and preventing you from bleeding out over a paperclip. Platelets are not white blood cells, but they do come from a bone marrow cell line. If red blood cells are delivery drivers and white blood cells are security, platelets are the emergency road repair crew. Just remember, blood isn't just red stuff. It's a complex living tissue with a fluid transport medium, specialized cells with very specific functions, and tight regulation that, when disrupted, gives us anemia, leukemia, clotting disorders, and more. And as histotechnologists, your job is often to recognize when one of these components isn't pulling its weight. All right, this slide looks busy, and that's because blood is busy. But don't panic. We're going to read this like histotechnologists, not like we're memorizing percentages for sport. Let's start on the left with the whole blood tube, because this is exactly what you see after centrifugation. White blood separates into approximately 55% plasma and 45% formed elements. That proportion alone already tells us something important clinically. If those numbers shift, we're dealing with anemia, polycythemia, dehydration, or plasma protein issues. When clinicians talk about hematocrit, they're talking about that red cell column, not the plasma. Plasma is that top layer you see there, which is in yellow. It's about 92% water, which makes it the transport medium for literally everything. The remaining 8% is where things get interesting. Plasma proteins. These are the heavy hitters. Approximately 60% of the plasma proteins is albumin. This maintains plasma osmotic pressure and major transport protein. If albumin drops, fluid leaks, and that results in edema. That's not abstract. You see it clinically. Then we have globulins. So gamma globulins, immunoglobulins, which is an immune response. Then we have beta globulins, which is responsible for transport and inflammatory proteins. And then fibrinogen, which is approximately 5%. This is essential for clotting, and it's present in plasma but absent in serum. This is why coagulation studies require plasma. You can't clot if you already removed the clotting factors. And then solutes. These include electrolytes, glucose, amino acids, hormones, vitamins, and metabolic waste. So essentially, plasma is the soup, solutes are the seasoning. Too much or too little of either, and the whole system is off. Okay, the formed elements, which is the bottom layer here shown in red. This is the cellular portion, and yes, it's dominated by red blood cells. So red blood cells make up probably greater than 99% of the formed elements. They're responsible for oxygen transport, they have no nucleus, and they have a highly specialized shape. Red blood cell morphology tells stories. So size, color, shape, inclusions, these are all diagnostic clues. And then the remainder of 1% or less than 1%, we have leukocytes. They're few in number, but huge in importance. So let's break them down. We have granulocytes, which are about 65% of that 1%, and then neutrophils, which is about 97% of granulocytes. Acute inflammation, the neutrophils are responsible for acute inflammation, phagocytosis, and they are the first responders. If you see a left shift, you know the bone marrow is panicking in a helpful way. Eosinophils, approximately 2%. These are allergies and parasites. Basophils, less than approximately 1%. We see these in allergic responses and histamine release. We also see agranulocytes, lymphocytes, approximately 30%. So immune reactions, B cells, T cells, natural killer cells. Monocytes are responsible for phagocytosis, and they become macrophages in the tissues. Monocytes are basically interns. They don't do much until they get to the tissue. Then they become absolute overachievers. So this diagram isn't about memorizing percentages. It's about understanding what's normal, what changes in disease, and why lab values shift the way they do. And for histotechnologists, it explains why morphology matters, because every shift in this balance leaves a visible trail. This slide answers a deceptively simple question. Where does blood come from? And the short answer is one stem cell with commitment issues. Every blood cell you've ever seen on a smear, red cells, neutrophils, lymphocytes, platelets, all start from one hematopoietic stem cell that immediately has to choose a career path. From there, it splits into two major progenitor lines. You have the lymphoid progenitor cells. These give rise to lymphocytes such as B cells, T cells, and NK cells. Think adaptive immunity and long-term memory. Or the myeloid progenitor cells. These produce everything else, such as our erythrocytes, neutrophils, eosinophils, basophils, monocytes, and our megakaryocytes, which we see in platelets. If it's not a lymphocyte, it came from the myeloid line. This matters a lot when you start differentiating leukemias. In adults, hematopoiesis mainly occurs in the bone marrow, specifically red marrow. So red marrow equals cellular, yellow marrow equals fat. If you're looking at a bone marrow biopsy and it's mostly adipocytes, production is down. Early in development, blood cells are produced in the liver and spleen. Over time, production shifts to bone marrow. Worthless but cool knowledge, your liver was once a blood factory. It has since retired. We also have extramedullary hematopoiesis. This is when an adult starts producing blood cells outside the bone marrow, usually in the spleen or the liver. This happens when bone marrow can't keep up, or the bone marrow is diseased or fibrotic. Extramedullary hematopoiesis explains hepatosplenomegaly and abnormal cellular clusters in organs that should not be doing this job anymore. Erythropoiesis, this is red blood cell production in the bone marrow. The key regulator here is erythropoietin, or EPO. It's produced by the kidneys. It's released in response to low oxygen, and it stimulates bone marrow to increase red blood cells. So chronic kidney disease results in low EPO, which results in anemia. No matter how healthy the marrow is, it can't work without instructions. So this slide explains why anemia can be marrow-related or kidney-related, why leukemia classification matters, why marrow biopsies exist, and why organ enlargement happens in blood disorders. And from a histotech standpoint, it explains why bone marrow is one of the most information-dense tissues you'll ever process. All right, take a breath. This slide looks terrifying, but it's actually just a family tree with commitment issues. What you're looking at is the entire life cycle of blood cells, from stem cell to circulation, organized by lineage and function. We'll start at the top, the pluripotent hematopoietic stem cell. Okay, this is living happily in the bone marrow. Pluripotent means it can become almost anything, but once it chooses, there is no going back. This cell is not morphologically distinctive on routine stains. You won't identify it on a smear. This is conceptual knowledge, not a visual one. From here, the stem cell splits into two major branches. A myeloid progenitor cell, which is the left side of the slide. This is the workhorse lineage. If it does stuff immediately, it's probably myeloid. From the myeloid line, we get granulocytes, neutrophils, eosinophils, and basophils. These mature through recognizable stages. So myeloblast, myelocyte, metamyelocyte, a band cell, or mature granulocyte. That band cell stage is clinically important. A left shift equals increased bands, which results in acute inflammation or infection. Neutrophils, they show up at acute inflammation, phagocytosis. They are our first responders. Eosinophils are present during parasites or allergic reactions. Basophils are for allergies and histamine release, so think tiny angry allergy confetti cannons. Now, monocytes, they circulate briefly in the blood and then enter tissues and become macrophages. So big cell, kidney-shaped nucleus, lots of cytoplasm. Okay, they look like they're judging the slide because they are. Megakaryocytes and platelets, this is always a student favorite. Megakaryocytes are huge. They have multi-lobe nucleus and they live in the bone marrow. They fragment to form platelets. Okay, platelets are not cells, they're cell fragments. They are basically biological glitter with a clotting mission. Then if it chooses the erythroid line, which is red blood cells, then red blood cells mature through erythroblast, normoblast, reticulocyte, and then a mature erythrocyte, right? Reticulocytes still have residual RNA. That's why special stains matter. And yes, mature red blood cells have no nucleus, are optimized entirely for oxygen transport, and are basically hemoglobin delivery vehicles. And then if that stem cell doesn't choose the myeloid progenitor cell route, it chooses the lymphoid progenitor cell line, which is on the right side of the slide. This slide is all about immune specificity and memory. From the lymphoid progenitor, we get B cells that mature in the bone marrow, differentiate into plasma cells, and are responsible for humoral immunity, which is our antibodies. Plasma cells, they have an eccentric nucleus plus a clock-faced chromatin. Once you see one, you'll never unsee it. Also T cells, they start in the bone marrow and they mature in the thymus. They are responsible for cellular immunity, direct killing, and immune regulation. T cells mature in the thymus. Pathology loves a good mnemonic, right? So T for thymus. This slide explains why leukemias are classified by cell lineage, why CBC differentials matter, why marrow biopsies tell such a detailed story, and why morphology plus clinical context equals diagnosis. From a histotechnology standpoint, this is the foundation for bone marrow interpretation, special stains, flow cytometry correlation, and understanding why something doesn't belong. Every abnormal blood smear, every marrow biopsy, every leukemia diagnosis starts right here, with where a cell came from and where it got stuck. Once you understand this map, the rest of hematopathology becomes pattern recognition, not memorization. Red blood cells are the ultimate single-purpose cell. They exist for one reason, oxygen delivery. That's it. No multitasking, no side hustles. If oxygen doesn't get where it needs to go, nothing else matters, and red blood cells are the delivery drivers. Red blood cells transport oxygen from the lungs to tissues throughout the body. Think of them as tiny oxygen Ubers, except they never cancel and they don't talk to you. Red blood cells originate from myeloid progenitor cells, not lymphoid. This matters later when we talk about anemias, bone marrow failure, and myeloproliferative disorders. Red blood cells mature through multiple nucleated stages, including inside the bone marrow. By the time they hit peripheral blood, they are fully differentiated. Mature red blood cells lack a nucleus. This is not a design flaw, it's an optimization. So no nucleus means more room for hemoglobin, greater flexibility, and better passage through capillaries smaller than the cell itself. They've removed all the furniture so they can carry more boxes, essentially. If you see a nucleus in a red blood cell in a peripheral blood, that is an immediate red flag. That's a nucleated red blood cell, and it usually means stress, hypoxia, or marrow pathology. Hemoglobin is the protein inside red blood cells that binds oxygen. It picks up oxygen in the lungs, releases it in tissues, and changes shape depending on oxygen saturation. Each hemoglobin molecule can bind 4 oxygen molecules, 1 per heme group. So red blood cell count times hemoglobin concentration equals oxygen delivery capacity. Red blood cell production is stimulated by erythropoietin, a hormone made by the kidneys. When the kidneys sense low oxygen levels or impaired oxygen delivery, they respond with, "We need more red blood cells immediately." This is why chronic kidney disease often leads to anemia, not because the marrow is broken, but because the signal is missing. EPO production increases when oxygen levels are low, hemoglobin is abnormal or ineffective. This condition is called hypoxia. Hypoxia does not mean anemia. You can have hypoxia with or without anemia. On a blood smear, red blood cells should be anucleate, uniform in size and shape, have a central pallor about 1/3 the diameter. When they're not, pathology starts telling its story. So, big picture takeaway from this slide, red blood cells are highly specialized, metabolically minimal, and completely dependent on hemoglobin and kidney signaling. They sacrifice complexity for efficiency, and it works remarkably well until it doesn't. This slide is where everything we just talked about with red blood cells becomes real. This is what you will actually see on smears in the lab and sometimes on exams. The top left is a peripheral blood smear. In this image, you're seeing red blood cells, the majority, neutrophils, segmented nuclei, purple, very hard to miss, and platelets, which are tiny purple dots doing their best. This is a normalish peripheral smear. What your eyes should immediately notice are that the red blood cells are anucleate, they are fairly uniform in size, and they have that central pallor, okay? They vastly outnumber everything else. If you can't find their white cells quickly, that's normal. Red blood cells are supposed to dominate the field. Okay. Now things start getting interesting. In the top right, this smear shows immature red blood cells mixed in with mature ones. These immature cells are slightly larger and more basophilic, and they are less uniform. Seeing immature red blood cells in peripheral blood usually means the bone marrow is under stress and the body is trying to compensate, such as bleeding, hemolysis, or hypoxia. The marrow is saying, "I know these aren't fully ready, but we're sending them anyway." Then the bottom left is the scanning electron microscopy of red blood cells. And in this image, we're seeing what they really look like in 3 dimensions. So they have that classic biconcave disc. They have a thin center, thicker edges, and they are designed for maximum surface area and flexibility. A fun but useful fact is that shape allows red blood cells to squeeze through capillaries smaller than their diameter, and it also maximizes gas exchange efficiency. If red blood cells lose this shape, think spherocytes, sickle cells, and target cells, and oxygen delivery suffers. In the bottom right, we have immature red blood cells or reticulocytes, okay? So where you see the arrow, these are reticulocytes, which are immature red blood cells. They still contain remnants of RNA. They appear blue-gray with special stains, and they represent recently released red blood cells from the bone marrow. Reticulocyte count tells us whether the bone marrow is responding appropriately or failing to respond. A high retic count means the marrow is responding. A low retic count means the marrow has a problem or a lack of EPO. Reticulocytes are a functional marker, not just a cell type. They help us answer, is anemia due to loss or destruction, or due to decreased production? Reticulocytes normally make up about 1 to 2% of circulating red blood cells. Any more than that, and something's going on. So, big picture takeaway, this slide reinforces 3 critical things. Red blood cells dominate peripheral blood. The shape, size, and maturity matter. And immature cells and circulation tell a story, and you need to learn to read it. Histology isn't just identification, it's also interpretation. Up to this point, we've talked a lot about red blood cells and oxygen delivery. Now we're shifting into the defense side of blood, white blood cells or leukocytes. Think of red blood cells as delivery trucks. White blood cells are the security team, each with a different job. Unlike red blood cells, white blood cells are not produced at a steady, constant rate. Their production increases when the body detects hormonal signals, inflammation, or immune system activation. When something is wrong in the body, you often see that response reflected in the blood smear. There are three main classifications of white blood cells. Okay? Function, morphology, and these are based on function and morphology. I'm sorry. These are monocytes, lymphocytes, and granulocytes. Okay? First one, monocytes are large phagocytic cells that circulate in the blood. Once they leave the bloodstream and enter tissues, they differentiate into macrophages, ingest and break down foreign material, and clean up dead cells and debris. Monocytes are like mobile recycling centers. They roam, collect debris, and then settle down in tissues to clean house. A histology clue, they are the largest white blood cell in the smear. They have an abundant pale cytoplasm, and the nucleus is often kidney-shaped or folded. If you can spot the size and the nucleus shape, you can usually identify a monocyte quickly. And number 2 is lymphocytes. Lymphocytes are responsible for targeted immune responses. They include B cells and T cells and natural killer or NK cells. If monocytes are the cleanup crew, lymphocytes are the detectives. They recognize specific targets and remember them. Histology clue, these are small cells. They have very dark, round nucleus, and they have a thin rim of cytoplasm, sometimes barely visible. Lymphocytes look simple, but they do very complex work. And then lastly, we have granulocytes. Granulocytes are named for their cytoplasmic granules, which contain enzymes and inflammatory mediators. These granules are important for breaking down antigens, driving inflammatory responses. There are 3 granulocytes you will absolutely see all of them on smears. Neutrophils. Neutrophils are the most common white blood cell and the first responders to infection and inflammation. They arrive early, phagocytose bacteria, and dominate acute inflammatory responses. They are multi-lobed nucleus, segmented, and they have pale cytoplasm with fine granules. Fun but useful fact, the more lobes you see, the more mature the neutrophil is. Bands. A band is an immature neutrophil. When bands appear in circulation, the bone marrow is releasing cells early, usually in response to infection or stress. Histology-wise, bands, the nucleus is curved or horseshoe-shaped, and it's not yet segmented. Okay? If you can distinguish a band from a segmented neutrophil, you're doing great. Next, we have eosinophils. Eosinophils are involved in allergic responses and defense against parasites. Histology-wise, they have bright red orange granules, and they're usually a bilobed nucleus. So an easy memory trick is that eosin equals eosinophilic granules. You can't miss. And lastly, basophils. Basophils are the least common granulocyte. They play a role in allergic reactions in the release of histamine and inflammatory mediators. Histology-wise, they have dark purple granules, and these granules often obscure the nucleus. If you think you see a basophil, look again. They're rare, but unmistakable when you do find one. So big picture takeaway for histotechnology is white blood cells reflect what's happening in the body, have distinct morphologic features, and tell a story when viewed on a smear. Your job is not to memorize everything they do, it's to recognize them, differentiate them, and connect structure to function. That's exactly what we'll keep building on. This slide is one you'll come back to again and again because this is where pattern recognition really starts to click. Everything on this slide is about what you see, not what you memorize. When you're looking at a blood smear, you should always ask yourself 3 questions. How big is the cell compared to red blood cells? What does the nucleus look like? And are there granules? And if so, what color? If you answer those 3 questions, identification gets much easier. So on the left side here, we see a granulocyte. We have granulocytes. Granulocytes are grouped together because they have visible cytoplasmic granules and more complex nuclei. First granulocyte is a neutrophil. They are the most common white blood cell we'll see. They have a multi-lobed or segmented nucleus, pale cytoplasm, and fine, lightly staining granules. Think of neutrophils as the plainclothes responder. They blend in and don't have flashy colors, but they do most of the work. If you see multiple nuclear lobes connected by thin strands, you're probably looking at a neutrophil. Then there's eosinophils. They are one of the easiest white blood cells to spot. They have a bilobed nucleus and large, bright red-orange granules. Eosinophils love eosin. They stain like they're showing off. If the granules jump out at you immediately, it's probably an eosinophil. And the last type of granulocyte, the basophil, these are rare but unmistakable. Dark purple to black granules, and the granules often obscure the nucleus. Basophils are like the overdressed guest. So much going on you can barely see what's underneath. If you think you found a basophil, you probably have. They don't show up often, but when they do, they're very dramatic. And then on the right side we have the agranulocytes. These lack prominent cytoplasmic granules and generally have simpler nuclear shapes. The first type is a lymphocyte. So small lymphocytes are extremely common on normal smears. They have a small size, about the size of a red blood cell or slightly larger. They have large dark brown nucleus and very thin rim of pale cytoplasm. Okay? Lymphocytes are all nucleus and no small top. If it looks like a nucleus with just a whisper of cytoplasm, then that's your lymphocyte. The last one is monocyte. Monocytes are the largest white blood cells you'll encounter in peripheral blood. So morphological clue is a large cell, kidney-shaped or folded nucleus, and abundant pale blue-gray cytoplasm. Monocytes are the SUVs of the blood, big, roomy, and built to haul debris. That abundant cytoplasm hints at their future life as macrophages in the tissue. So notice the red blood cells surrounding each white blood cell. Those are your built-in size references. Also notice the platelet near the lymphocyte. Tiny, purple, and easy to miss if you're not looking carefully. Always scan the background. Red blood cell morphology, platelet presence, and white blood cell distribution all matter. Again, this slide isn't about memorizing labels. It's about training your eyes to compare size, recognize nuclear shapes, and identify granules or lack of them. Once you can do that, the names come naturally. Platelets may be the smallest things on blood smear, but they do a disproportionate amount of work, and they're easy to underestimate if you're not paying attention. The first big concept to lock in is platelets are not cells. They're cytoplasmic fragments that break off from a very large precursor cell called the megakaryocyte, which lives in the bone marrow. Think of megakaryocytes as a big loaf of bread and platelets as the crumbs that break off, except these crumbs are essential for survival. Megakaryocytes are enormous cells with multi-lobed nuclei. Instead of dividing like normal cells, they shed pieces of cytoplasm directly into the bloodstream. Platelets do not have nuclei. They appear as small, purple-blue dots on a right Giemsa stain. They're usually much smaller than red blood cells, so think specks, not circles. Confusing platelets with stain precipitant or debris tends to be a common mistake that students make. Platelets tend to be uniform in color and often appear in small clusters. Once platelets enter circulation, they just cruise around quietly until there's vascular injury. When damage happens, platelets adhere, then aggregate, then help form the foundation of a clot. An analogy here are that platelets are the emergency road repair crew. They rush in, block traffic, and stabilize the situation until permanent repairs can happen. Platelets are short-lived, only about 7 to 10 days in circulation. That means they must be produced continuously. The bone marrow health directly affects platelet number. If platelet counts are low, always think bone marrow production, destruction, or consumption. And yes, you'll see that reflected on smears. When you're scanning a peripheral smear, platelets tell you a lot. Are they present? Are they clumped? Are they giant platelets or unusually small? And do they seem proportional to the red blood cell field? A worthless but useful knowledge is that platelet clumping can falsely lower automated platelet counts, which is why manual smear review still matters. Platelets may be tiny, but they are essential, constantly replaced, and directly tied to bone marrow function. If you don't consciously train your eye to look for them, they're easy to miss, and missing them means missing important diagnostic clues. Okay, this slide looks simple, and it is, but the numbers here explain a lot of what you'll see later in disease states and on peripheral smears. So let's walk through these one by one. Red blood cells, they circulate for about approximately 120 days, right? So red blood cells are the long haulers of the blood. Again, they circulate for about 120 days, squeezing through capillaries, delivering oxygen, and slowly accumulating wear and tear. Think of red blood cells like delivery trucks with no GPS, no engine repair, and no ability to replace parts. Eventually, they just wear out. Old or damaged red blood cells are removed primarily by the spleen, so changes in lifespan show up as increased reticulocytes or abnormal morphology. A shortened lifespan equals anemia, even if production is normal. And then we see granulocytes. Granulocytes, especially neutrophils, live fast and die young. About 4 days in circulation and often much less once they enter tissues. Granulocytes are like disposable gloves, designed for short-term, high-risk work, not longevity. Rapid turnover means the marrow must respond quickly. In infection, you'll see bands and left shifts because the body can't wait for full maturation. Then there's lymphocytes, which are a mixed group. Some circulate briefly while others migrate into tissues or lymphoid organs and hang around longer. That is about 1 to 2 weeks, right? Small lymphocytes on a smear can look deceptively boring, but don't underestimate them. They represent adaptive immunity. Changes in number or appearance often correlate with immune activation or suppression. Fun fact here is some memory lymphocytes can persist for years, but the ones you're seeing in routine blood are often on a shorter timeline. Then monocytes. Monocytes again are 1 to 2 weeks. They spend a short time in the bloodstream, then exit into tissues. Once there, they differentiate into macrophages where they may live much longer. So blood monocytes is a precursor. Tissue macrophages is the real cleanup crew. If monocyte counts are elevated, think chronic inflammation or tissue injury. Analogy here is monocytes are interns, macrophages are the full-time staff. Then we have platelets. Platelets have one of the shortest lifespans, about 7 days. That's why platelet counts can drop quickly and recover quickly if the bone marrow is healthy. Rapid turnover means production must be continuous. Disorders affecting marrow or consumption show up fast in platelet counts and smear appearance. Disease states can shorten lifespan, so hemolysis, immune destruction. They can increase destruction through splenic sequestration. They can force early release of immature cells. So bottom line for histotech students is this. If you know how long a cell is supposed to live, you'll better understand why the smear looks the way it does when something goes wrong. All right, this is where all that structure and function knowledge starts paying rent. Blood assessment is one of the fastest, most information-dense diagnostic tools in medicine. By looking at which cells are in excess, reduced, or abnormal, clinicians can start narrowing down things like anemia, infection, inflammation, or hematologic malignancy. And while you may not be running the CBC yourself, what shows up here often determines what tissue gets biopsied, what stains get ordered, and what slides land on your bench. So CBC stands for complete blood count. And think of the CBC as a snapshot of the blood at one moment in time. Not the whole story, but a very good starting chapter. Okay? A complete blood count consists of 1, white blood cell count and differential. This tells us how many white cells are present and what types they are. So elevated neutrophils, think acute inflammation or infection. Increased lymphocytes, think viral or chronic immune processes. A left shift with bands, marrow is working overtime. The differential is like checking not just how many people are at work, but which departments showed up. The second component is the platelet count. Platelets are small but mighty. Abnormal counts can point to bleeding disorders, bone marrow dysfunction, and increased consumption, such as clotting or inflammation. Low platelets often trigger marrow exams. You'll see megakaryocytes take center stage in those cases. The third component is the red blood cell count. This is the number of red blood cells circulating. On its own, it's useful, but it really shines when interpreted alongside hematocrit and hemoglobin. Changes in red blood cell count often correlate with altered morphology on smears. Anemia isn't just low red blood cells, it's about why they're low. Then we have hematocrit, or HCT. Hematocrit represents the percentage of blood volume occupied by red blood cells. So if you imagine spinning down a tube of blood, HCT is how much of that tube is red cell layer. Hematocrit roughly equals 3 times the hemoglobin in healthy adults. Not a rule, but a nice mental check. Then another component is hemoglobin, or HGB. Hemoglobin measures how much oxygen-carrying protein is present. This matters because you can have normal red blood cell numbers that don't work well, or fewer red blood cells that are packed with hemoglobin. Hypochromia, polychromasia, and ansocytosis will reflect changes that start here. And then lastly, we have the red blood cell indices. This is where the CBC gets histotech adjacent in a big way. Indices help classify anemia by cell size, hemoglobin content, and hemoglobin concentration. Red blood cell indices are like reading the fine print. Same number of cells, very different stories. Indices guide smear review. Smear findings confirm or challenge the numbers. This is where morphology and metrics meet. So big picture takeaway on this slide is CBC values don't exist in isolation. They guide diagnostic workups, influence biopsy decisions, and help pathologists decide where to look next. If you understand the CBC, you understand why certain tissues, stains, and sections end up in front of you. This slide looks math heavy at first glance, but don't panic. Red blood cell indices are really just a translation tool. They take raw numbers from the CBC and turn them into information about cell size, hemoglobin content, and staining appearance. In other words, this is how the lab values start predicting what you're going to see on a blood smear. We have the mean cell volume, or MCV. It tells us the average size of the red blood cell. The formula is listed here, so MCV equals HCT divided by red blood cell. Clinically, this helps classify anemia as microcytic, as small cells, normocytic, which is normal cells, or macrocytic, which are large cells. Low MCV equals small, crowded red blood cells with increased central pallor. High MCV is larger cells, sometimes oval and sometimes oddly shaped. MCV answers the question, are we dealing with espresso cups or soup bowls? Then we have the mean cell hemoglobin concentration, or MCHC. Okay? This reflects how concentrated hemoglobin is inside the red blood cell. The formula is MCHC equals HGB divided by HCT. Okay? This is your best numeric clue for chromasia. Low MCHC is hyperchromatic cells with exaggerated central pallor. Normal MCHC is classic pink red blood cells. And then high MCHC, which is rare, is dense dark cells. So think spherocytes. And some worthless but useful knowledge is MCHC is one of the most tightly regulated indices. When it's abnormal, pay attention. And lastly, mean cell hemoglobin, or MCH. MCH tells us the average amount of hemoglobin per red cell, regardless of concentration. The formula, MCH equals HGB divided by RBC. This tends to track with MCV. Bigger cells usually carry more hemoglobin, smaller cells carry less. The changes in MCHC often correlate with overall cell color and size, but not central pallor specifically. MCH asks how much hemoglobin is in each backpack. MCHC asks how tightly is it packed. This triangle diagram is important because it shows that HGB, HCT, and red blood cell count are the foundation. The indices are derived values, not independent measurements. Why this matters for histotechnology is that indices guide smear review. Smear morphology confirms or challenges the numbers, and then discrepancies often trigger further workups, such as including bone marrow biopsies. Red blood cell indices don't replace morphology, they point you toward it. This slide walks us through the life of a blood sample, and honestly, it's a great reminder that automation is amazing, but it's not the whole story. So step one, everything starts with a standard vena picture. Whole blood is drawn and placed into a tube containing anticoagulant so the cells don't decide to clot together before we get a chance to look at them. At this point, the sample is still a mixed crowd. So red blood cells, white blood cells, platelets, plasma, they're all just hanging out together. Think of this like dumping every Lego piece into one giant bin. Useful, but not very organized yet. The tube then goes into the hematology analyzer, which rapidly generates a CBC and differential. These machines are fast, consistent, and excellent at counting and flagging abnormalities. They give us counts, indices, and graphs and scatter plots. They alert when something looks off, but, and this is important, machines recognize patterns, not nuance. Okay? A flag doesn't mean a diagnosis. It means, hey human, come look at this. Then this is where step 3, which is blood smear preparation, and this is where histology skills really shine. A drop of blood is placed on a slide and spread into a 1-cell thick smear. Thickness matters. Too thick and cells overlap, too thin and everything gets distorted. After staining, usually with Wright or Wright Giemsa, cells suddenly become readable. We'll see nuclear detail, cytoplasmic granules, and color, shape, size, or inclusions. This is cytology meets morphology. You're evaluating cells in their natural environment, not embedded in paraffin, but the principles are the same. The best diagnostic information is often found in the feathered edge of the smear, not the thick middle. Then step 4, we're moving on to the microscope, and this is where machines hand the baton to humans. On the smear, you can identify specific white blood cell types, assess red blood cell size, shape, and color, spot immature cells, inclusions, or abnormal morphologies. See things machines can't reliably classify. This is where you might notice the left shifts and bands, toxic granulation, atypical lymphocytes, platelet clumping, or even subtle dysplasia. Automated results guide us, but morphology confirms or corrects them. And why this matters for histotechnology students, although you may not be running CBCs, but you are trained to recognize abnormal cells, evaluate staining quality, understand what normal should look like, and appreciate how disease changes morphology. The blood smear is a perfect example of how numbers in histology tell the same story from different angles. So final analogy here, the analyzer reads the headline, the smear reads the fine print, and sometimes the fine print changes everything. Okay. This slide is one of the most important bridges in the hematopoietic system. It's where lab values meet morphology. If you understand this table, blood smears suddenly make a lot more sense. Think of these measurements as descriptions of what your eyes would see under the microscope, just expressed in numbers first. So hematocrit, HCT, is how much space red blood cells take up. Hematocrit tells us the percentage of blood volume occupied by red blood cells. So low hematocrit is anemia. High hematocrit, we have polycythemia. Low hematocrit usually means the field looks empty, so fewer red blood cells, more white space. High hematocrit means the smear looks crowded, like rush hour traffic. Hematocrit is the how full is the room measurement. Then we have hemoglobin, again, HGB, how much oxygen carrying power is present. Hemoglobin measures the oxygen carrying protein, not the number of cells. So low hemoglobin is anemia, high hemoglobin is polycythemia. Okay? You can have normal red blood cell numbers, but low hemoglobin per cell, and that still causes anemia. Low hemoglobin often shows up as pale cells with exaggerated central pallor. Okay, next up is the red blood cell count, and these are how many cells are there. This is a straight up count. Too many is anemia, too few is anemia, too many is polycythemia. But by itself, it doesn't tell you why. It just tells you quantity, not quality. Red blood cell count alone is one of the least helpful values unless you pair it with indices and morphology. Then we have the mean cell volume, which size matters here. So it tells us how big the average red blood cell is. So low MCV is microcytosis, and then high MCV is macrocytosis. This is exactly what you're doing when you say, these red blood cells look small. These are huge and kind of sloppy. MCV is asking, are we dealing with marbles, ping pong balls, or softballs? And then we have the mean cell hemoglobin concentration, also MCHC, right?
and this is where color tells a story. The MCHC reflects how well hemoglobinized the cell is. Okay? Low MCHC, we have hypochromia, and then high MCHC, we have hyperchromia. Hyperchromia is rare, but it is real. Okay, this is central pallor, right? Too much pallor is hypochromic. Little to no pallor, we have hyperchromic. This is why you cannot interpret anemia without looking at a smear. This table is basically a translation guide. The machine gives you the what, the smear tells you the why. Even if you never calculate these values, you recognize them morphologically. You understand what abnormalities look like. You know when a smear doesn't match the numbers. That skill is exactly why human review still matters.
This slide is all about patterns, not memorization. White blood cell values tell us what type of immune response is happening, and your job as histotechnologist is to connect these numbers to what you see on the smear. Think of the white blood cell differential as a roll call. It tells us which cells are present, missing, or overrepresented. So we have total white blood cell count. This is how busy is the immune system overall. So normal white blood cell count falls within a pretty wide range. Low white blood cell count equals leukopenia. High white blood cell count equals leukocytosis. This tells you something is happening, but not what. That's why the differential matters. Total white blood cell count is like knowing how many people are in the building, not who they are. Okay? We have neutrophils, which are the first responders. Neutrophils make up the largest percentage of white blood cells, which makes sense. They're the immune system's emergency response team. So low neutrophils, we have neutropenia. High neutrophils, we have neutrophilic leukocytosis. On a smear, increased neutrophils often look numerous, sometimes less segmented, and sometimes with toxic granulation or vacuoles. Neutrophils go up with acute inflammation and bacterial infections. If neutrophils are high, the fire department has been called. Then we have lymphocytes. These are the planners and specialists. They are more about targeted and adaptive immunity. So low lymphocytes is lymphopenia. High lymphocytes, we have lymphocytosis. On a smear, lymphocytes have a large dark nucleus, very thin rim of cytoplasm, and often stand out clearly from red blood cells. Lymphocytes increase more commonly with viral infections or chronic immune responses. These are the detectives, slower but very specific. Then there's eosinophils, the allergy and parasite specialists. They normally make up a very small percentage of the white blood cells, but high eosinophils equals eosinophilia. These are your easy to spot cells, bright pink to red granules, and a bilobe nucleus. Eosinophils increase with allergic reactions, asthma, and parasitic infections. If you see a lot of eosinophils, your brain should immediately think allergy or parasite. Then there's basophils, rare but dramatic. Basophils are normally barely present. High basophils results in basophilia. They're hard to miss and hard to see. Dark purple granules, and the granules often obscure that nucleus. Basophilia is uncommon but can be associated with chronic inflammation and certain hematologic disorders. Basophils are like the one loud person in the room, rare but very noticeable. This table isn't meant to be memorized, it's meant to be interpreted, okay? Key takeaway, the machine counts cells, you recognize patterns. When you're reviewing a smear, you already know what the differential suggests. You're looking to confirm or question the numbers. You're trained to catch abnormalities machines may miss. And that's the value of morphology. Up to this point, we've talked a lot about counts, differentials, and patterns, but when blood work raises concern, this is often the next step, a biopsy. This slide is especially important for you because once tissue is obtained, histotechnologists become central to the diagnostic process. A bone marrow biopsy is performed by inserting a specialized needle into bone, most commonly the posterior iliac crest, to obtain marrow. Bone marrow is where all blood cells originate, so when something looks abnormal in the peripheral blood, the marrow is often the next place to look. Once collected, marrow can be smeared directly onto slides for cytologic evaluation or processed, embedded in paraffin, sectioned, and stained, just like other tissue biopsies. This means you may be working with decalcified marrow cores, H&E sections, or special stains or immunohistochemistry, depending on the question being asked. If the peripheral blood is the finished product, bone marrow is the factory. These biopsies are performed to further evaluate abnormal blood counts, suspected hematopoietic cancers, and bone marrow disorders affecting cell production. Histology matters here because pathologists are evaluating cellularity, too many versus too few cells, distribution of cell lines, and presence of abnormal or immature cells. Machines can't do that. Slides can. A lymph node biopsy. The slide also mentions lymph node biopsy, which is commonly used to assess for lymphoma. Blood and marrow tell you about circulating and producing cells. The lymph nodes tell you about immune organization and architecture. For lymph nodes, architecture is everything. Normal follicles versus effaced architecture, diffuse versus nodular patterns, and cell size, shape, and distribution. This is where good processing, embedding, and sectioning are critical for diagnosis. This slide is your reminder that lab values raise questions and tissue answers them. The quality of fixation, processing, sectioning, and staining directly impacts whether a diagnosis can be made confidently. And some worthless but useful knowledge, bone marrow cores are some of the most unforgiving specimens. Poor decalcification or processing can completely compromise interpretation. So wrap-up comment here on this slide, blood tests suggest something is wrong. Biopsies show what is actually happening, and histotechnologists are the bridge between the patient and that diagnosis. Okay, now that we understand how blood cells are produced, circulated, and are evaluated, we can talk about what goes wrong most often, and more importantly for you, what those problems look like histologically. Think of this slide as a preview of why blood and bone marrow specimens exist in the first place. So anemia. Anemia is the most common blood disorder you will encounter. At its core, anemia means not enough functional red blood cells to deliver oxygen. But not all anemia looks the same under the microscope, and that's where histology becomes critical. We have iron deficiency anemia. This is the most common type of anemia worldwide. Red blood cells are microcytic, so smaller than normal, and red blood cells are hypochromatic, and they have an increased central pallor. The donut hole looks too big. Think of these red blood cells like underfilled water balloons, same shape, but not enough hemoglobin inside. MCV and MCHC numbers hint at iron deficiency, but the smear confirms it visually. Then we have vitamin B12 deficiency. This one looks completely different. Macrocytic red blood cells, so big cells, often oval rather than round. They have hypersegmented neutrophils may be present. Neutrophils with more than 5 nuclear lobes are a classic clue pointing toward B12 deficiency, sometimes spotted before lab values flag it. So yes, sometimes the neutrophils snitch first. Then there's infections. Blood infections don't just change numbers, they change cell populations and appearances. There's leukocytosis, which simply means increased white blood cells, most often due to infection. We'd see elevated neutrophils and presence of bands, which again are immature neutrophils. If mature neutrophils are trained firefighters, bands are the recruits sent out early because the fire is spreading fast. When you see bands on a smear, the bone marrow is basically saying, we're short-staffed, send everyone. Malaria. This is one of the coolest and most horrifying things you'll ever see on a blood smear. Parasites inside red blood cells, ring forms or intracellular inclusions. Malaria is diagnosed almost entirely by microscopic evaluation, not machines. This is one of those times where histology, not automation, makes the diagnosis. Then we have human immunodeficiency virus, or HIV. It primarily affects lymphocytes, especially the CD4 positive T cells. What you may see indirectly is lymphopenia on CPC, reactive or atypical lymphocytes, and increased susceptibility to secondary infections. What you won't see HIV on a slide, but you will see the immune system unraveling. Primary cancers of the blood. These are cancers that originate in blood-forming tissues, not metastases. So leukemia begins in the bone marrow and spills into the bloodstream. You'd see large numbers of immature cells, or what we call blasts, crowding out of normal marrow elements, and then loss of normal maturation pattern. Imagine a factory that keeps producing unfinished products and never completes anything. Eventually, the warehouse fills with useless inventory. That's leukemia. Then there's lymphoma, which primarily involves lymphoid tissue. So architecture of lymph nodes, loss of normal follicles, and diffuse sheets of abnormal lymphocytes. This is where fixation, section thickness, and proper orientation can literally determine whether a diagnosis is possible. And multiple myeloma. This cancer involves plasma cells. So you'd see increased plasma cells in marrow and a clock-faced chromatin. Some worthless knowledge that becomes very useful is when plasma cells start stacking up in marrow, normal blood cell production drops, leading to anemia, infections, and bleeding problems. One cell line misbehaving can affect all three. Every disorder on this slide eventually leads to tissue evaluation. Peripheral blood smears, bone marrow aspirates, bone marrow core biopsies, or lymph node biopsies. And automated analyzers raise that suspicion. So final takeaway here is that numbers suggest disease, cells reveal disease, and tissue explains disease. And histotechnologists are the ones who make those cells visible. All right, now we officially enter anemia territory. Anemia is not a single disease, it's a finding. Think of anemia as the laboratory equivalent of your car's check engine light. It tells you something is wrong, but not what is wrong. Anemia refers to a decrease in red blood cells, hemoglobin, or hematocrit below normal levels. In simple terms, not enough oxygen carrying capacity in the blood. The image on this slide shows that beautifully. On the left, a normal concentration of red blood cells. On the right, fewer red blood cells per volume of blood. Same plasma, same vessel, just fewer delivery trucks carrying oxygen. From a histology standpoint, anemia is rarely diagnosed just by a number. Yes, the CBC tells us anemia exists, but the blood smear tells us why. Because anemia doesn't just change quantity, it changes appearance. Under the microscope, we start asking, are the red blood cells too small or too large? Are they pale or normally pigmented? Are they uniform or wildly variable in size and shape? Are mature cells being released? This is where histology earns its paycheck. Imagine red blood cells as delivery trucks. Normal blood means the highway's full of red trucks. Anemia and traffic is light. But now we ask, are the trucks tiny? Are they huge? Are they missing cargo? Or are they falling apart on the road? Each one of those clues points to a different type of anemia. Depending on the cause, anemia may show microcytosis, just small red blood cells, macrocytosis, just large red blood cells, hypochromia, which is pale cells with large central pallor, or anisotysis, which is variation in size, poikilocytosis, which is variation in shape, reticulocytosis, which is increased immature red blood cells. All of that is visible with proper smear preparation, a good, bright Giemsa staining, and a careful histotech eye. A fun but useful fact, your body produces about 2 million red blood cells every second. So when anemia develops, one of three things is usually happening. The marrow isn't making enough, cells are being lost through bleeding, or cells are being destroyed too quickly. And each of those mechanisms creates different histologic patterns. As histotechnologists, you may be working with peripheral blood smears, bone marrow aspirates, core biopsies showing erythroid hyperplasia, iron stains, or reticulin stains. Anemia is often the reason the specimen exists. Your processing, section quality, and staining directly impact whether the pathologist can determine production problem, destruction problem, or deficiency problem. So just remember, anemia is not low blood. It is a story told by red blood cells, and the microscope is how we read it. Okay, now that we've introduced anemia, let's tighten the definition and connect it directly to what we see on slides. At its core, anemia means abnormally low hemoglobin. Not just fewer red cells, but less oxygen carrying capacity overall. That low hemoglobin can happen in three basic ways. Too few red blood cells, too little hemoglobin inside the cells, or a combination of both. And each of those mechanisms produces distinct histologic patterns. So we have cause number 1, which is decreased red blood cell number. This means the marrow is simply not producing enough red cells. Histologically, we may see low red RBC count on CBC, fewer erythrocytes per field on the smear, and possibly increased reticulocytes if the marrow is trying to compensate. In bone marrow sections, this can appear as decreased erythroid precursors or marrow replaced by fat, fibrosis, or tumor. Think of this as a factory problem, fewer products coming off the assembly line. Then we have cause number 2, decreased hemoglobin in cells. Here the body is producing red blood cells, but they're poorly equipped. On a peripheral smear, this shows up as hypochromia, so enlarged central pallor, pale appearing cells, often microcytosis as well. The image on this slide shows a classic example of microcytic hypochromic anemia, commonly seen in iron deficiency. These cells are small, pale, and inefficient oxygen carriers. They exist, they just aren't doing their job well. Cause number 3 is a combination of both. This is extremely common. Patients may have fewer red blood cells and decreased hemoglobin within those cells. Histologically, this often produces marked anocytosis, poikilocytosis, and a wide variety in staining intensity, and also mixed cell populations. In other words, it results in a messy slide. And messy slides usually mean something systemic is going on. So we have some universal symptoms. Because hemoglobin carries oxygen, anemia leads to chronic fatigue, shortness of breath, pale skin and mucous membranes. And from a histology standpoint, pallor correlates directly with decreased hemoglobin density inside red cells. So less hemoglobin equals less pink. So where does the lab come in? So step 1 for a diagnosis is always the CBC. This tells us the hemoglobin level, the hematocrit, the red blood cell count, the indices. But numbers alone do not tell the full story. That's where the smear comes in, right? Once anemia is identified, we ask why. There are 2 major categories. Failed red blood cell production. This may involve iron deficiency, vitamin deficiencies, bone marrow suppression, or chronic disease. Histology may reveal microcytic cells, or macrocytic cells, or an abnormal precursor maturation, and changes in marrow cellularity. Second one is red blood cell loss, and this includes hemorrhage or destruction, such as hemolysis. In these cases, the marrow often tries to compensate. On the smear, you may see polychromasia, increased reticulocytes, or larger bluish tinted cells. The marrow is essentially yelling, "I'm trying." If red blood cells are delivery trucks, production failure is not enough trucks made. Hemoglobin deficiency is trucks without cargo. Hemorrhage is trucks falling off the highway. And hemolysis are trucks being destroyed early. The smear shows us which problem is happening. And some worthless but cool knowledge, red blood cells cannot repair themselves. There's no nucleus, no ribosomes, no protein synthesis. So once damaged, that's it. So any abnormality in shape, color, or size reflects a problem that occurred during production, not afterward, which is why blood smears are such powerful diagnostic tools. So remember, anemia is not just low hemoglobin. It is a disorder of production, a disorder of content, or a disorder of survival. And histology is how we tell the difference. Let's talk about blood loss anemias, which are some of the most straightforward anemias to understand, but also some of the easiest to misinterpret if you only look at numbers. The key concept here is loss, not defective production. The bone marrow is capable of making normal red blood cells, they're just being lost faster than they can be replaced. Acute blood loss means a rapid loss of a large volume of blood. Examples include trauma, surgery, or internal hemorrhage. In these situations, the primary danger is not anemia at first, it's shock caused by loss of circulating blood volume. From a histology perspective, something important happens early on. The red cells that remain are normal in size. They are normal in hemoglobin content, So on a peripheral smear, red blood cells look completely normal. You'll see no microcytosis, no hypochromia, no weird shapes. The problem isn't quality, it's quantity. We have temporary dilutional anemia. So after acute blood loss, the body pulls fluid from tissues back into the bloodstream. This restores volume but dilutes the remaining red blood cells. That's why labs may show decreased hematocrit, decreased hemoglobin, even though the cells themselves still look normal. Histologically, this produces normocytic, normochromatic anemia, meaning normal size, normal color, just fewer cells per field. The bone marrow responds quickly. Within days, you may see increased reticulocytes, mild polychromasia on smear. Those slightly bluish cells represent immature red blood cells being pushed out early. The marrow is basically hitting the emergency button. Okay, and chronic blood loss is very different. Instead of a sudden hemorrhage, this involves slow loss of small amounts of blood over time. Common causes include abnormal menstrual bleeding, chronic gastrointestinal bleeding. Because the loss is gradual, the body initially keeps up until it can't. So early on, chronic blood loss still appears as normocytic, normochromic anemia. The marrow is producing normal cells, iron stores are still adequate, and the smears look fairly unremarkable. Over time, however, iron stores become depleted. When that happens, the red blood cells become smaller, hemoglobin content drops, and the anemia transitions into microcytic hypochromic anemia. This is why chronic blood loss is one of the most common causes of iron deficiency anemia. Histologically, you'll begin to see increased central pallor, decreased cell size, anisocytosis, poikilocytosis, so the smear evolves as the disease progresses. Think of red blood cells like money in a bank account. Acute blood loss equals someone emptied your account overnight. Chronic blood loss is slow daily withdrawals. At first, everything looks fine. Eventually, you have overdraft. In blood loss anemias, the bone marrow works normally. The cells are initially normal. The problem is loss, not production. So smear appearance depends on how fast blood is lost, how long the loss has been occurring, and whether iron stores are depleted. So key patterns to remember: acute blood loss means normocytic and normochromic, right? Chronic blood loss, early on we'd have normocytic and normochromic, and then chronic blood loss later we'd have microcytic and hypochromic. Same disease processes, different histologic stages. After acute blood loss, hemoglobin and hematocrit may initially appear normal. Why? That's because plasma and red cells are lost together. The anemia doesn't show up until fluid shifts occur, which is why timing matters when interpreting labs and why smears add so much diagnostic value. Bottom line, blood loss anemias teach us that numbers alone never tell the whole story. Histology shows us what stage the patient is in and whether the marrow is keeping up or falling behind. Now we're moving into hemolytic anemias, which are defined by one simple problem. Red blood cells are being destroyed too early. Normally, a red blood cell lives about 120 days. In hemolytic anemia, that lifespan is dramatically shortened, sometimes to just days or weeks. This premature destruction of red blood cells is called hemolysis. In hemolytic anemias, the bone marrow is capable of producing red blood cells. In many cases, it's working overtime. The issue is not production, the issue is survival. Red blood cells are being removed from circulation before they should be. Because red blood cells are dying early, several predictable findings appear. Anemia, so fewer circulating red blood cells. You'd have increased erythropoietin levels as the kidneys sense hypoxia. Shortened red blood cell lifespan, right? So hypercellular bone marrow, especially erythroid hyperplasia. We'd see an elevated reticulocyte count. That last one is very important for histotechnologists. So reticulocytosis equals compensation. When red blood cell destruction increases, the marrow responds by releasing cells early. On peripheral smear, this shows up as polychromasia, so slightly larger bluish red cells with increased reticulocytes. This tells us the marrow is trying to compensate. High reticulocyte count is one of the biggest clues that hemolysis is occurring. So think of red blood cells like delivery trucks. In normal conditions, trucks last 120 days. In hemolytic anemia, trucks keep breaking down mid-route. The factory, or bone marrow, works overtime. But if the trucks keep getting destroyed, deliveries still fall behind. There are several mechanisms that can destroy or damage red blood cells. The first one is genetic red cell defects. These include problems with red blood cell membranes, hemoglobin structure, or enzymes inside the cell. Defective cells are less flexible and can't tolerate normal circulation stress. Number two is antibodies against red cells. In immune-mediated hemolysis, antibodies bind to red blood cell membranes. The cells become targets for macrophages, and then partial phagocytosis leads to shape changes, especially spherocytes. Number three, hypersplenism. The spleen acts as a quality control organ. If red blood cells are even slightly abnormal, they get trapped, inspected, and destroyed. So an overactive spleen equals increased hemolysis. Number four is rough vascular surfaces. Anything that mechanically damages red cells can cause hemolysis. So artificial heart valves, narrowed vessels, and microangiopathic conditions. This produces red blood cell fragments. Histologically, you may see schistiocytes, helmet cells. These are classic hemolysis clues. And then there are also lesions associated with hemolytic anemia. So two major tissue level changes occur. We have bone marrow hyperplasia, so we'd see increased erythroid precursors, crowded marrow spaces, and high cellularity. The marrow is in constant emergency mode. And also splenomegaly, so we'd see increased red blood cell destruction, increased macrophage activity, and expansion of red pulp. This is why many hemolytic anemias present with enlarged spleens. Despite all this destruction, the red blood cell indices often show normocytic and normochromatic. Why? Because the cells being produced are normal, they just don't live long enough. The abnormality is quantitative, not qualitative. Hemolytic anemia typically shows decreased hemoglobin, increased reticulocytes, increased LDH, increased bilirubin. Normal or slightly elevated MCV and smear findings are often the biggest clue. So in hemolytic anemias, red blood cell production is normal or increased, bone marrow is hypercellular, reticulocytes are elevated, and the peripheral smear tells the story. If you see polychromasia, red blood cell fragments, spherocytes, increased reticulocytes, think hemolysis. In worthless but fun knowledge, the spleen is sometimes nicknamed the graveyard of red blood cells, which sounds dramatic, but is honestly pretty accurate. So bottom line here is hemolytic anemias are destruction problems, not production problems. Often normocytic and normochromatic, they are characterized by reticulocytosis, and they are best recognized by smear morphology. For histotechnologists, the microscope often gives the diagnosis long before the numbers do.
So now that we understand what hemolytic anemia is, which is premature blood cell destruction, let's look at the most common types you'll encounter, especially from a histology and peripheral smear perspective. Remember, for us, the diagnosis often begins under the microscope, not on a lab printout. So the first one is sickle cell anemia. This is one of the most recognizable hemolytic anemias. It's caused by an abnormal form of hemoglobin called hemoglobin S. Under low oxygen conditions, hemoglobin polymerizes, the red blood cell becomes rigid, and the cell bends into a characteristic sickle shape. On peripheral smear, you may see sickle-shaped erythrocytes, target cells, and polychromasia from increased reticulocytes. These rigid cells break easily, get trapped in capillaries, are rapidly removed by the spleen. This leads to chronic hemolysis. So normal red blood cells are soft rubber discs. Sickle cells are like bent plastic straws. Once deformed, they don't bounce back. Then we have thalassemia. Thalassemia is a globulin chain production problem, not an iron production problem. The iron chains are produced in unequal amounts, leading to ineffective erythropoiesis, fragile red blood cells, and increased destruction. Common features on smears include microcytosis, hypochromia, target cells, and ansocytosis and poikilocytosis. These cells are smaller and structurally unstable, making them prone to hemolysis. Thalassemia can look like iron deficiency anemia, but iron studies are normal. Same slide appearance, but very different cause. Then there's hypersplenism. Here the red cells themselves may be normal. The problem is the spleen. An enlarged or overactive spleen removes red blood cells, platelets, and white blood cells at an excessive rate. Histology-wise, we might see enlarged red pulp, increased macrophage activity, and accelerated destruction of circulating cells. Think of this as overzealous quality control. The spleen becomes the employee who throws out perfectly good products because the label is slightly crooked. Then we have hereditary spherocytosis. This condition involves defects in the red blood cell membrane proteins. Because of membrane loss, the red blood cells lose surface area and the cells become round instead of biconcave, and these are called spherocytes. Smear findings, we'd see dense round red blood cells, no central pallor, and increased MCHC. The spherocytes are less flexible and cannot pass through splenic sinusoids easily, so they're destroyed early. If you see spherocytes without iron deficiency or immune disease, think hereditary spherocytosis. And then there's glucose 6-phosphate dehydrogenase deficiency, or G6PD. This is an enzyme deficiency that protects red blood cells from oxidative damage. Without G6PD, oxidative stress damages hemoglobin. Hemoglobin precipitates inside the cell. You have classic morphological findings such as Heinz bodies, which are denatured hemoglobin, bite cells after splenic macrophages remove Heinz bodies. Triggers for this include certain medications, infections, and fava beans. Yeah, that's real. Worthless but true knowledge. Favism is the term used for hemolysis triggered by fava beans in G6PD deficient patients. We have microangiopathic hemolytic anemia. In this condition, red cells are mechanically destroyed as they pass through damaged vessels. So causes include fibrin strands, narrowed vessels, and abnormal endothelial surfaces. On smear findings, this is a big one for histology. We'd see schistiocytes, helmet cells, and fragmented red blood cells. These cells look like they've gone through a blender because essentially they have. Imagine trying to push water balloons through a barbed wire fence. That's what red cells experience in microangiopathic hemolysis. Although the causes differ, all hemolytic anemias share common features, such as shortened red blood cell lifespan, elevated reticulocyte count, hypercellular bone marrow, increased bilirubin, and characteristic smear abnormalities. As a histotech, when reviewing blood smears, ask yourself, are cells being destroyed early? Do shapes look abnormal? And are fragments or reticulocytes present? If the marrow is working overtime but anemia persists, think hemolysis. Each hemolytic anemia leaves a morphologic fingerprint. So sickle cells is sickle cell disease. Target cells is thalassemia. Spherocytes is hereditary spherocytosis. Bite cells will see G6PD deficiency. And schistiocytes is microangiopathic hemolysis. Your microscope tells the story long before the diagnosis is signed out. Sickle cell anemia is one of the most well-known genetic disorders of hemoglobin structure, and from a histology standpoint, it's one of the most visually distinctive. This condition occurs when normal hemoglobin A is replaced by hemoglobin S due to a single amino acid substitution in the beta globulin chain. That tiny molecular change has massive downstream effects on cell shape, flexibility, and survival. Under normal oxygen conditions, red blood cells are soft, flexible, and biconcave. This allows them to squeeze through capillaries smaller than their own diameter. In sickle cell disease, hemoglobin S polymerizes when oxygen levels drop. Long, rigid fibers from inside the cell. The red blood cell becomes elongated and crescent-shaped. Once this happens, the cell loses flexibility, becomes fragile, and cannot return to its normal shape. Normal red blood cells are like soft, gummy candies. Sickle cells are like dried licorice, stiff, brittle, and very unforgiving. On a right Giemsa-stained peripheral smear, you may see classic sickle-shaped erythrocytes, elongated curved cells with pointed ends, target cells, polychromasia from increased reticulocytes. These abnormal shapes are not artifacts. They reflect actual structural distortion of the membrane by hemoglobin polymers. So the normal red blood cell lifespan is approximately 120 days, and a sickled red blood cell lifespan is about 10 to 20 days. Because they are mechanically fragile, easily ruptured, and rapidly removed by the spleen, this constant destruction results in chronic hemolytic anemia. We have vascular occlusion. So beyond hemolysis, the sickle shape creates another major issue, so mechanical obstruction of small blood vessels. So rigid sickle cells, they stack together, they adhere to the endothelium, and so they block capillary flow. This then leads to tissue ischemia, infarction, so dead tissue, and recurrent pain crises. The diagram on this slide shows where repeated vascular occlusion occurs. From a tissue perspective, brain, which causes infarcts that leads to strokes. Lungs, we'd see pulmonary infarcts and pneumonia. Kidneys, hematuria and infarction. And then the spleen, repeated infarcts, which eventually lead to splenic atrophy. Bones, we'd have marrow hyperplasia and infarction, and then skin and digits, we'd see ulcers and gangrene. Each complication traces back to the same problem, the distorted red cells blocking blood flow. Because red blood cell destruction is constant, the bone marrow attempts to compensate. So histologic features would include hypercellular marrow, expanded erythroid lineage, increased reticulocyte release. And this explains why many patients show reticulocytosis on CBC, polychromasia on peripheral smear. The marrow is working overtime, it just can't keep up. Early in life, we'll see splenic changes, so repeated sequestrin causes splenomegaly. Over time, we'd see repeated infarcts occur. Functional splenic tissue is destroyed, eventually leading to autosplenectomy, the spleen essentially destroying itself. So loss of splenic macrophage function increases susceptibility to infection, so especially encapsulated organisms. And why this matters for histotechnologists is that sickle cell disease is one of the best examples of how a molecular defect produces a morphological abnormality that leads directly to tissue injury. So when reviewing blood smears, key clues include abnormally shaped erythrocytes, evidence of hemolysis, elevated reticulocytes, and chronic changes in the spleen and marrow. This is pathology driven by shape and rigidity, not by cell count alone. So, big takeaway from this slide is that sickle cell anemia is a hemoglobin structural disorder, a chronic hemolytic anemia, a disease of abnormal morphology. Every complication from anemia to infarction begins with this simple fact: a red blood cell that cannot bend cannot survive. All right, this is your official brain break. If your neurons are starting to feel a little hypoxic, if all red blood cells are beginning to look the same, or if you just heard the words normocytic, normochromatic one too many times, this is your moment. Take a second, stretch, refill your coffee, pet a dog or a cat if one is nearby. Blink aggressively at the screen. You've just made it through. It's a lot of microscopic information, I know, packed into a short time. But we'll come back for part 2 of this lecture whenever you're ready.